Okay, let's unpack this. We are jumping into a deep dive on acute diabetic emergencies.
Mm-hmm.
This is, high stakes, time sensitive stuff. It's absolutely essential knowledge for anyone on the front lines of medicine.
It really is.
Yeah.
Our goal today is to give you a clear, step-by-step roadmap. We're talking diagnosis, the core pathophysiology, and of course the clinical management for DKA, HHS, and severe hypoglycemia.
These are real life and death scenarios.
Exactly, not just academic curiosities. They demand precise, immediate intervention.
And we're going to start right where a lot of the confusion happens, which is contrasting DKA and HHS. They're both driven by high glucose, but metabolically, they're worlds apart.
That metabolic fingerprint, as you put it, is the core distinction. If you look at the diagnostic tables, they split in two key areas. First, just the sheer level of hyperglycemia.
Okay.
For DKA, you're looking at plasma glucose over 250 milligrams per deciliter. But for HHS, it's often in a different universe, typically over 600, and it's not uncommon to see it go well past 1,000.
So high glucose is the headline for both, but the real smoking gun is in the other lab work, the acidosis, the ketones.
Precisely. DKA is the crisis of acid. You see this triple whammy in the labs. The pH plummets below 7.3, your bicarb crashes below 18, and you get a high anion gap.
Which points directly to
Significant uncontrolled ketosis. Your body is churning out these acidic ketone bodies.
And in HHS.
The story's completely flipped. Ketosis is minimal, sometimes totally absent. So the patient avoids that profound acidosis. Their pH stays above 7.3, and their bicarb is generally above 15.
And the reason for that difference, the pathophysiology of it all, it comes down to just a tiny bit of residual insulin, right?
That tiny amount is the entire key. In DKA, you have an absolute, or at least a severe relative, lack of insulin. That total deficiency unleashes all the counter-regulatory hormones.
Glucagon, cortisol.
Right, and catecholamines. And that combination drives massive lipolysis, the breakdown of fat. That floods the liver with free fatty acids, which then get converted into those ketone bodies, hence the KNN in DKA.
But in HHS, there's just enough insulin hanging around, maybe only 10% of normal, to stop that process?
Exactly. It's just enough to put the brakes on the fat breakdown and the ketone production. So, no acidosis.
Yeah.
But it is nowhere near enough to handle the massive glucose load.
So the sugar just keeps climbing.
It spirals into those stratospheric heights we mentioned. The primary driver in HHS becomes extreme dehydration and hyperosmolality, not acid.
And you really see this in how the patients present. DKA patients often have that nausea, vomiting, and small respiration.
That deep, rapid breathing, the body's desperate attempt to blow off CO2 to compensate for the acid.
And sometimes that severe abdominal pain, the pseudoperitonitis, that can really throw you off.
It can, and what's really important to remember is that the severity of DKA does not always correlate with how high the glucose is. You can have a very sick patient with a glucose of just 300.
Which brings us to a huge exception, euglycemic DKA.
Yes. This is where the glucose headline is so misleading.
Tell us about that.
So in euglycemic DKA, the blood glucose is often under 180, but the patient is in severe ketosis and acidosis. It's rare, but you have to know about it.
Where do you see it?
We see it pretty often in patients on SGLT2 inhibitors, sometimes during pregnancy or prolonged fasting. The glucose looks lower because the kidneys are just spilling tons of it into the urine, but metabolically, they are still starved for insulin. The ketogenesis is running wild.
So despite these differences, DKA and HHS share this one immediate life-threatening problem, profound dehydration.
Osmotic diuresis. The excess glucose in the kidneys acts like a sponge, just dragging massive amounts of water and electrolytes right out of the body. In HHS, this is devastating because the dehydration leads to extreme hyperosmolality. It can literally pull water out of brain cells.
And this brings us to one of the biggest lies the lab values will tell you in DKA. Let's talk about the potassium paradox.
Oh, this is a critical teaching point. You have to internalize this.
Go on.
The acidosis and the lack of insulin, they work together to shift potassium out of the cells and into the bloodstream. So your initial serum potassium, your K plus insulin, it might look normal, might even look a little high.
And you think, okay, great. One less thing to worry about.
Big mistake. A normal or high serum potassium in a DKA patient always indicates a large total body potassium deficit. Always. Because as soon as you start treatment...
With insulin and fluids.
Right. The insulin drives that potassium right back into the cells. The acidosis corrects. And that hidden deficit is suddenly revealed. You can bottom out their potassium and cause a fatal arrhythmia.
That is the perfect segue into management then. The management triad for both DKA and HHS.
3 pillars. Aggressive fluid replacement, a titrated insulin infusion, and essential potassium supplementation.
And fluids come first, always.
Fluid replacement is the immediate, non-negotiable priority, especially in HHS. Before you even think about aggressively lowering the blood sugar, you have to fix the volume deficit. We start aggressively with isotonic saline, 0.9% ACL.
How much are we talking?
A liter, maybe a liter and a half, in the first hour for an adult, or about 15 to 20 mils per kilogram per hour.
But you can't just keep flooding them with normal saline forever.
No, you have to use smart fluids. Once the patient is more stable, or if their corrected sodium is normal or high, which is common in HHS, you switch. You move to half isotonic saline, 0.45% ACL.
To replace that free water deficit.
Exactly, without overloading them on sodium. And then comes the final adjustment.
Adding sugar back in.
It sounds counterintuitive, but yes. When the blood glucose gets down to the 250 to 300 range, we switch the IV fluids to a solution with 5% dextrose, or DeFi.
Why is that so important?
2 reasons. First, it prevents you from causing hypoglycemia, but more importantly, it allows you to continue the insulin infusion. We need that insulin running until the ketoacidosis is totally shut down and the acidosis resolves, which takes much longer than just getting the glucose number down.
Okay, pillar 2. Insulin therapy. We're aiming for a steady hand here.
Continuous low-dose IV insulin is the standard, usually around 0.1 units per kilo per hour, and it has to start in parallel with the fluids.
Although in kids, there's a specific warning.
Yes, in children, you should delay the insulin for 1 to 2 hours after the fluids start. And the pacing of that glucose drop is critical. We want a controlled descent.
What's the target rate?
A steady, predictable fall of about 50 to 70 milligrams per deciliter per hour. If it's too slow, you can double the rate. But if it falls too fast, you risk creating a dangerous osmotic shift in the brain.
And speaking of the brain, let's circle back to that pediatric warning.
Absolutely. In children, an initial IV insulin bolus should be avoided completely. It's been shown to increase the risk of cerebral edema. The goal is to keep the blood glucose between 140 and 180 after those first few hours, letting the osmolality come down slowly and safely.
So once the DKA is resolved, glucose under 200, bicarb up, pH normalized, it's time to get off the IV drip. But this is a high-risk moment.
It really is. It's so easy for patients to relapse if this transition is botched. The golden rule is therapeutic overlap. You have to give the subcutaneous basal and premeal insulin 1 to 2 hours before you stop the IV drip.
To make sure there's no gap in coverage.
Exactly. You need that subcutaneous insulin to be absorbed and active before the IV insulin wears off.
Okay, let's touch on the bicarbonate debate. Should we be giving it to correct the acidosis?
Generally, no. Bicarb is usually avoided. The acidosis will correct with just fluids and insulin. However, there are some guidelines that suggest it for exceptionally severe acidosis.
Like what level?
When the pH is 6.9 or lower. The idea is to prevent negative cardiac effects. But it's a risky move. It can worsen the hypokalemia and, more subtly, cause something called paradoxical CNS acidosis, which can actually worsen the patient's level of consciousness.
Which brings us to the ultimate terror scenario, cerebral edema.
It's the complication that keeps everyone up at night. It's rare, but it's frequently fatal, and it usually shows up 4 to 12 hours after you've started treatment.
So your own therapy can cause it.
If it's too aggressive, yes. The risk factors are a rapid decline in plasma osmolality, a really high fluid rate, or again, using bicarbonate initially. If you suspect it, you have to act immediately.
Push what?
Mannitol or hypertonic saline. You need to pull that fluid out of the swollen brain, and fast.
Okay, that wraps up the high glucose crises. Let's pivot now to the other end of the spectrum. Severe hypoglycemia, a crisis of acute brain fuel deprivation.
Right. Physiologically, we define hypoglycemia as a plasma glucose of 54 milligrams per deciliter or less. That's the level where we can detect cerebral function impairment.
But hopefully the body's alarm bells go off before then.
Usually, yes. Our counter-regulatory responses, glucagon and epinephrine, they kick in around 65 to 70.
But for patients on intensive insulin therapy, that alarm system can get worn out. This is hypoglycemia-associated autonomic failure, or HAF.
HAF is essentially a dulled alarm. When you have frequent low blood sugar episodes, it dampens that protective epinephrine response. This leads to hypoglycemia unawareness.
The patient no longer feels the warning signs.
Exactly. They don't get the sweating or the shaking. They go straight from feeling fine to being confused or collapsing. The good news, though, is that HAF is reversible.
How?
By strictly avoiding any low blood glucose for 2 to 4 weeks. It allows that alarm system to reset itself.
So clinically, there are two main groups of symptoms.
Yes. First, you have the autonomic symptoms, the adrenaline response. Sweating, palpitations, shaking, hunger. These are the early warnings that are lost in
Yeah,
HAE.
and if it keeps dropping.
Then you get the neuroglycopenic symptoms. This is the brain being starved of fuel. Confusion, drowsiness, odd behavior, slurred speech, and eventually stupor or coma.
And we know iatrogenic hypoglycemia is a huge problem, especially in type 1 diabetes.
It's a massive problem. The DCCT trial found rates as high as 62 severe episodes per 100 patient years. But type 2 patients are at risk too, especially those on certain oral agents.
Like sulfonylureas.
Right. An agent like glibenclamide has a long half-life and binds tightly to the beta cell. Its effect is prolonged. Newer agents like nataglinide are much shorter acting, which means a lower risk of severe, sustained hypoglycemia.
So, management. If the patient is conscious.
Simple oral carbohydrates, juice, glucose, tabs. But if they're severe or unconscious, outside of a hospital, a trained family member or friend can give a glucagon injection. That mobilizes glucose from the liver. But you have to follow that immediately with oral carbs once they're conscious. In the ER, we go straight to an IV bolus of concentrated glucose, D50, followed by a continuous infusion.
Okay, our final crisis. A quick but important look at lactic acidosis, especially with metformin.
Lactic acidosis, or LA, is another severe metabolic acidosis. We define it as a blood lactate over 5 with a pH below 7.35.
And there are two types.
Type A is from hypoperfusion or hypoxia, like in shock. Type B isn't related to perfusion. It's often caused by drugs, liver disease, or even severe hypoglycemia.
And metformin-associated LA is a type B.
It is. And while the incidence is very, very low, about 0.03 cases per 1,000 patient years, the mortality is tragically high, close to 50%.
How does it happen?
Well, metformin works partly by inhibiting the mitochondrial respiratory chain. If the drug accumulates, usually because the kidneys aren't clearing it, it can cause lactic acid to build up faster than the body can handle. The trigger is usually metformin accumulation during a moment of system stress.
Like getting sick.
Exactly. The classic case is a patient with some underlying renal insufficiency who gets gastroenteritis, becomes dehydrated, the kidneys take a hit, and the metformin levels skyrocket.
Which brings us perfectly to prevention and the sick day rules. This is crucial advice for every patient.
The absolute #1 non-negotiable rule, especially for type 1 patients, is this: never stop your insulin completely, even if you're not eating. The stress of the illness is actually increasing your body's demand for insulin.
Stopping insulin is a fast track to DKA.
It is. The next pillar is monitoring. Check blood glucose frequently, and if it goes above 270, you must check for ketones every 4 to 6 hours.
And hydration.
Absolutely. Ample non-carb fluids, 100 to 150 milliliters every hour. And crucially, if you are becoming dehydrated or seriously ill, you stop the metformin and call your provider.
So when does it become an ER trip?
If you have poor glucose control plus altered consciousness, persistent vomiting or diarrhea for more than 6 hours, or ketones that won't clear despite extra fluids and insulin, that's when you go. You cannot manage DKA or HHS at home.
So we've covered the whole spectrum. DKA, the crisis of acid, HHS, the crisis of extreme dehydration, and hypoglycemia, the crisis of brain fuel deprivation.
And we've highlighted those hidden dangers, the potassium paradox, HAAF, and the critical importance of those sick day rules. The real takeaway is that while we have protocols, care must always be individualized, especially in the elderly or those with comorbidities.
To reinforce that, let's end with the final thought for you to consider. Imagine a 75-year-old patient with type 2 diabetes. They present with acute confusion, a glucose over 800, minimal ketones, and severe hypernatremia. Based on everything we've discussed, what is the single most important intervention you must prioritize before aggressively lowering their blood sugar, and why must that intervention be titrated so carefully over a long period? Think about the immediate risk to the brain,